Welcome to the United States Civil War, ladies and gentlemen, even though it doesn't really look like much yet. In this sketch, we'll start by peeking at this newspaper here that's reminding us that our patient is presenting with predominantly left sided abdominal pain. And here he is, this poor soul crawling out of the water. Meet James. He's a 22-year-old male presenting to the emergency department with the abdominal pain we already mentioned, a fever, as evidenced by this flame bandana, and, drum roll please. That is a terrible drum roll. Whatever, good enough. Bloody diarrhea. Ew. And a lot of diarrhea. Like a lot. Like 15 bowel movements since it started a lot. Based on the stem, it sounds like it's fairly mucousy stool too. Eesh, and look, it just keeps going and going. This is because James here has had multiple episodes in the past of similar situations. Abdominal discomfort and diarrhea. Sometimes even bloody diarrhea. Alright, so just a short little introduction to the case here. The question is asking what would be the histologic findings on biopsy taken during colonoscopy? Wow, that's a really specific question. Well, in order to answer that question, we really need to know what the diagnosis is first. Let's look at this. Young guy, left lower quadrant pain, diverticulositis? Wait, that's not a thing. Diverticulosis? Diverticulitis? But he's so young. Neither of these are particularly common in someone his age, and typically patients with diverticulosis have painless bloody diarrhea, and if it's diverticulitis, it's usually pain with non bloody diarrhea. So it sounds like these don't fit. Okay, start again. Young guy, left lower quadrant pain, bloody diarrhea, and fever? Systemic infection? Or maybe just systemic inflammation? That's ringing some bells, and it's definitely involving his bowels. So, could it be one of the inflammatory bowel diseases? If you haven't had the chance already, make sure to watch our other historically inaccurate on the Civil War, but medically accurate on Crohn's disease sketch, which will contrast nicely with this sketch. There's no right sketch to start with, but they are complementary, so we recommend checking them out one after the other. In this sketch, however, we'll be talking about ulcerative colitis, or UC, which is an inflammatory bowel disease, or IBD, that causes ulcers and inflammation throughout, well, the colon. While UC and Crohn's disease share many features like abdominal pain, diarrhea, and fever, there are big differences in both the pathologic and clinical findings of the two diseases. The age of onset of UC, just like Crohn's disease, is usually between 15 and 40 years, though there may be a second peak between 50 and 80. But for all intents and purposes, think young-ish. IBD is also more prevalent in North America and Europe, and less prevalent in Asia, Japan, and South America. Ulcerative colitis and Crohn's disease are more common in individuals with Jewish ancestry and in white ethnicity compared to Black and Hispanic populations. While in the Crohn's disease sketch we hit the pathological features first, we are going to hold off for a bit in this one, because for our clinical case, we have to be sure that the diagnosis is correct before we try and answer the clinical question. As with James in our clinical case, patients with UC typically come in with diarrhea, the bloody type. The most prominent clinical feature of UC to remember is hematochezia, or blood per rectum, which can range in severity from mild to life threatening. These patients typically have a history of attacks of bloody diarrhea of varying degree that can last weeks and even months. This is why this trail of diarrhea mud behind our patient has obviously been going on and off for a while. Bloody diarrhea is a key clue for UC when trying to decide which of the two IBDs our patient has. Because very rarely does Crohn's disease have frank bleeding per rectum. Patients with UC typically present with abdominal pain that's worse in the left lower quadrant, especially during flares. This is because the rectosigmoid colon is always involved in UC. And while physical exam is usually pretty normal with UC, extensive inflammation, especially during flares, may lead to mild to moderate tenderness to palpation. And because there's so much systemic inflammation going on, there may be a low-grade fever happening in these patients. Alright, so this pretty much fits for our clinical case. But really, there's other causes of abdominal pain and bloody diarrhea. How can we be sure that this is what James has? There's a few other features that we should clue into. As with Crohn's disease, not only do you have to worry about manifestations in the bowel, but throughout the body as well. Extraintestinal manifestations of ulcerative colitis include arthritis, which is typically HLA-B27 positive, uveitis, or inflammation of the uvea, a middle layer of the eye, and skin changes, including erythema nodosum, which is a painful erythematous nodular rash, and pyoderma gangrenosum, which are large ulcers that appear infected but are actually sterile. These are both most commonly found on the legs. There's also primary sclerosing cholangitis, which occurs in patients in Crohn's disease as well, but there's a much higher association of PSC with UC than there is with Crohn's disease. In ulcerative colitis, the prevalence of developing PSC has been estimated as high as 90%. PSC is important because if untreated, it leads to end stage liver failure, which is even worse than it sounds. Finally, there's ankylosing spondylitis. This is a classic buzzword for IBD. Patients present with worsening back pain and eventual bending forward of the spine. Remember that ankylosing spondylitis is our classic bamboo spine, hence the very out of place bamboo that we have growing next to the medical tent. Hang on a sec. That sounds familiar. Didn't James from our clinical case have something like that? Back pain and a hunched over appearance? Well, I think we have our most likely diagnosis. Let's look at some confirmatory tests. There are several findings to look for in a patient coming in with suspected ulcerative colitis. On labs, expect to see elevated inflammatory markers such as CRP and ESR, though it's important to remember that neither are specific for UC. Patients with UC may also have anemia, especially iron deficiency anemia from all that blood loss and malabsorption. However, they may also have other causes of anemia. In addition to iron deficiency anemia, patients may have anemia of chronic disease. It is chronic after all, or even autoimmune hemolytic anemia. However, if you have to choose the most common cause, for example, on a test, go with iron deficiency anemia, which is why a repairman is dropping all his iron tools into the water. Think of this like our patients dropping all their iron out through their colon. Stool should always be checked for C. diff as well, as it's a common complication of UC and must be ruled out in cases of colitis. That's some oddly shaped shrapnel there, soldier. But let these antibody belly skewers remind you that patients with UC may also have a number of autoantibodies, the most common being P. ANCA. While it's not diagnostic, it does raise the suspicion for an autoimmune inflammatory process such as UC instead of other causes of GI bleeding, like diverticulosis. In some cases, a double contrast barium enema may be performed to evaluate the mucosa of the colon. A classic finding on barium enema is the lead pipe appearance of the colon due to loss of colonocostra combined with extensive wall thickening. Which is why we have this Union soldier dropping his barium into the tailpipe, if you know what I mean. This used to be the gold standard of diagnosis, but not anymore. Patients who come in with abdominal pain and diarrhea also usually have an abdominal radiograph or CT, but the findings of inflammation are nonspecific and can be seen with many inflammatory conditions. The real diagnosis of UC comes by means of endoscopy. Colonoscopy with tissue biopsy should be performed for suspected UC, as the clinical findings combined with tissue samples are the only reliable means of diagnosis. Colonoscopy should not be performed during acute flares due to increased risk of perforation in the setting of high inflammation, and the patient should be treated through the flare until it's over. Colonoscopy should be performed after the flare is resolved, usually 6 weeks after. All right, here's the meat of the discussion. And I think we're going to get the answer to our clinical case too. Remember our friend James? It's been a little while since we talked about him. The question at the beginning asked what likely histological features we would see on tissue biopsy. Of course, we're going to wait until we get him through the flare, just like we talked about. A key histologic feature of UC is that inflammation is limited to the mucosa and submucosa only, i.e., not transmural. This is why stricturing and fistula formation are rare with UC compared to Crohn's disease. Even so, the inflammation leads to a friable, erythematous, really angry looking mucosa on endoscopy. Under the microscope, inflammatory infiltrates and crypt abscesses may be prominent. These are limited to a histological finding, however, and typically don't cause larger abscesses. Granuloma formation is not, I repeat, not a feature of UC, setting it apart from Crohn's disease. Another thing to remember is that the inflammation in UC always involves the rectum and moves proximally, sparing the anus. As you can tell with this happy fellow getting pulled along by this non inflammatory anus life preserver. This means UC is limited to the colon and rectum only, unlike the mouth to anus nonsense of Crohn's disease. As the inflammation of UC spreads proximally, it does so in a continuous fashion, unlike the skip lesion seen in Crohn's. This actually creates another feature commonly seen in UC: pseudopolyps. Good job, guy. Looks like these holes are all patched up by our repairman. These pseudopolyps aren't polyps at all, but regenerating normal mucosa. These little islands of regenerating mucosa stick out above the friable, inflamed segments, giving them a polyp like appearance. Well, all of these just about sum up the histological findings you should expect in patients with ulcerative colitis. And there's our answer for our clinical case. But we still have a few more topics to cover. James here isn't going to get better on his own. How do we go about treating ulcerative colitis? Turns out it's very similar to treatment of Crohn's disease. Patients with mild to moderate UC can be treated with 5-ASA compounds such as sulfasalazine in both oral or preferably suppository forms. But come on, man, you can't just do that with a flag. Just wrong. Yikes. Let this five-pointed star's southern placement remind you that treatment of UC often involves suppository 5-ASA compounds like sulfasalazine or mesalamine. If 5-ASA compounds aren't enough, steroids can be given as well, such as budesonide or prednisone. Steroids for this use come in oral, IV, and suppository forms. Speaking of IV, patients with more severe cases, especially during flares, may be treated with IV steroids, which should be tapered as tolerated, and immunomodulators such as 6-mercaptopurine, azathioprine, or infliximab. Other examples of severe cases are generally if patients are diagnosed younger, which means they can expect a more severe course, or if the inflammation involves the whole entire colon versus just the left side in less severe cases. The most severe cases, such as toxic megacolon, require much more attention. First, patients should be treated with high dose IV steroids, fluid and electrolyte replacement, and IV antibiotics. The most common regimen is a combination of methylprednisolone, ciprofloxacin, and metronidazole. These patients are sick, usually in the ICU, and require intensive monitoring and serial abdominal exams. Why? Because they can perforate, which of course means they're going to surgery. We'll talk about the surgical treatment of this in just a moment. First, we're going to talk about the surgical options to prevent scary things like toxic megacolon. In the end, 20 to 30% of patients will require surgery for ulcerative colitis, with many being elective. This typically occurs when patients have failed medical management. Restorative proctocolectomy with ileal pouch anal anastomosis, IPAA, whew, that's a mouthful, can be performed to remove the colon and rectum in patients with ulcerative colitis. Anastomosis means a connection, typically sewn or stapled, and remember that procto refers to the rectum. So the name of the surgery is a complex way of saying removal of the colon and rectum and reconnection of the anus to a pouch made of ileum. Since the entire colon and rectum is removed, there is no more vulnerable mucosa to cause nasty symptoms. In some cases, proctocolectomy with ileoanal anastomosis will not only cure disease, but restore bowel continuity. This is done with a J pouch, which helps maintain continence. Put simply, the distal ileum is anastomosed to itself in a side-to-side, i.e. longitudinal fashion, making a little pouch that helps with maintaining the patient's continence after removal of the rectum. In short, you can think of the J pouch as surgical recreation of the rectum. The pouch is then anastomosed to the anus, restoring continuity with the outside world. Patients who undergo surgery also get to avoid many of the nasty side effects from chronic steroid therapy. Furthermore, colectomy can actually lead to improvement or even resolution of extraintestinal manifestations. All except ankylosing spondylitis and primary sclerosing cholangitis, that is. Once those start, they don't stop. Okay, so that's the elective version of surgery for ulcerative colitis. What about emergent surgeries? One of the indications for surgery during a UC flare is pretty obvious when you remember all that bloody diarrhea they can have. Massive hemorrhage that doesn't stop on its own. And especially if it's causing hypotension from hypovolemia, by which I'm talking about hemorrhagic shock. It's a big reason to bring a patient with UC right to the OR. Another emergent indication for surgery in ulcerative colitis is toxic megacolon. Remember we mentioned this just a bit ago? Toxic megacolon, also known as fulminant colitis, is a late complication of ulcerative colitis in which inflammation extends to the smooth muscle layer, paralyzing the colon and rectum and leading to severe dilation of the colon and systemic toxicity. The right colon is typically more dilated than the left, but any segment dilated greater than 6 centimeters in combination with clinical findings is enough to diagnose toxic megacolon. A trend that you should notice emerging is that when you dilate any part of the bowel, you're at higher risk for perforation. This is because dilation causes compression of the blood vessels, leading to ischemia, and then pop, perforation and intra-abdominal sepsis is a feared complication of toxic megacolon and is an absolute indication for emergent surgery. Emergent surgery for ischemia, necrosis, massive hemorrhage, or perforation usually entails either subtotal colectomy with end colostomy or a total colectomy with ileostomy, depending on how much the colon can be salvaged. Why the ostomies? Well, if you try and make a primary colonic anastomosis, i.e., reconnect the colon with the remaining rectum, with all that inflammation in an already sick patient, it's a shoo in for anastomotic leak, breakdown, and sepsis. All around bad news. In these cases, a Hartmann's procedure may be performed. In a Hartmann procedure, the distal colon is excised, the rectal stump is left in place, and an end colostomy is made. Since the rectum is left in place, the surgery isn't curative for ulcerative colitis. Definitive surgery should be performed as an elective procedure when the patient is stable. To help you remember the parts of a Hartmann procedure, just think back to this soldier here, strapped to the remaining stump and holding up a segment of bowel. Sort of like pulling up bowel for an ostomy. Elective colectomy isn't just good at preventing painful symptoms, though. In the first 10 years of disease, there's about a 2 to 5% chance of developing colorectal cancer due to UC. After that, it increases by 1% per year. So carry the one, and you've got a 20 to 25% chance of cancer after 30 years of disease. If you're diagnosed at 18, that means a 1 in 4 chance of cancer by the time you're 48. Not cool. Preventative proctocolectomy, which again is the same elective procedure with creation of a J pouch, is offered after about 10 years to patients interested in preventing cancer. Which, I mean, who doesn't want to prevent cancer? And while we're on the subject of cancer, patients with UC should have screening colonoscopy every 1 to 2 years, starting at or before 8 years after the initial diagnosis. To help you remember this, we've sketched in this soldier inspecting a rusty cannon with the colonoscopy flashlight, though his glasses have fallen off and are forming an oddly less than 8 shape. If patients show high-grade dysplasia on biopsy or start developing highly dysplastic polyps, it's time to consider surgery. This is even more important in UC because cancer can just grow spontaneously from the flat colon wall, unlike most other cases that stem from a pre-existing polyp. All right, that about does it for ulcerative colitis. Let's sum all this up. Ulcerative colitis is one of the inflammatory bowel diseases, the other being Crohn's disease. Typical patients are young, between 15 and 40, and are typically of white and or Jewish descent. Patients typically present with abdominal pain of the left lower quadrant, bloody diarrhea, and may have a low-grade fever. They likely also have a history of similar episodes of abdominal pain and diarrhea, either bloody or not. Patients may have extraintestinal manifestations, including arthritis, uveitis, skin changes such as pyoderma gangrenosum and erythema nodosum, primary sclerosing cholangitis, and ankylosing spondylitis. Patients may have elevated ESR, CRP, and anemia, usually due to iron deficiency. C. diff should also be tested for in all patients with profuse diarrhea. Patients with UC may also have elevated P. ANCA, but this is not diagnostic. Barium contrast enema may demonstrate lead pipe colon due to severe inflammation and sloughing of the mucosa, leading to the loss of normal colonocostra and wall thickening from edema. The gold standard for diagnosis is colonoscopy with biopsy. Colonoscopy should not be performed during an acute flare. Colonoscopy and biopsy should show inflammation involving only the mucosa and submucosa, crypt abscesses and inflammatory infiltrates, and involvement of only the colon and rectum. UC does not involve the anus, nor should it have granuloma formation, both of which are more characteristic of Crohn's disease. Inflammation in UC is continuous, as compared to the skip lesions seen in Crohn's disease. Medical treatment of UC is typically started with 5-ASA compounds. to which it may be necessary to add steroids to. Severe cases may require IV steroids, or the immunomodulator drugs 6-mercaptopurine or azathioprine, or biologics such as infliximab. In the most severe cases, such as toxic megacolon, IV steroids, antibiotics, and supportive therapy should be initiated. Emergent surgery is often necessary in these situations. The surgical treatment of ulcerative colitis begins with elective proctocolectomy with ileal anal anastomosis. This is where the colon and rectum are removed, and then a pouch is made of ileum and then connected to the anus. This is a curative procedure and may reduce complications, including extraintestinal manifestations. Elective colectomy may also be performed for colorectal cancer prevention, which has a very high prevalence in patients with UC, and its incidence increases with length of time from initial diagnosis. Colonoscopic surveillance should also be performed in patients with UC, starting before or by 8 years after diagnosis and occurring every 1 to 2 years. Emergency surgery may be necessary in cases of massive hemorrhage or toxic megacolon, or in cases of perforation and sepsis. The choice emergency procedure is a Hartmann procedure, where the involved part of the distal colon is removed, the rectal stump left in place, and an end colostomy is brought up to the abdominal wall. If the entire colon is involved, a total colectomy may be required, in which case an ileostomy will be brought up. Wait, is this just another Civil War reenactment? Hey guys, liven up. We're bored over here. No, it's real. Everyone, get out of here, quick. Oh, run away!